Hello, I'm David Linch and I've been a professor of haematology at UCL for over 30 years. I'm a hemato-oncologist and I'm in the unusual position of having two main interests. Clinically, I've been interested in the management of patients with lymphoma, particularly in developing high-dose therapy strategies, whereas in the laboratory, my main interest has been hemopoiesis and acute myeloid leukemia. I did my first SHO job at the Hammersmith Hospital, at that time there were 12 jobs advertised all at the same time, and various people were invited to interview on the same day, and at the end of the interview process they selected 12 people, brought you into a room and then told you what job you were going to have, regardless of what jobs you said you wanted. And I got assigned to the hematology team. And as it turned out to be a really inspiring choice for me. I was there just before Sir John Dacey and David Galton retired, who were the sort of founding father of British laboratory and clinical haematology, respectively. And then amongst the younger consultant staff, there was Danny Kotowski, John Goldman, and Ted Gordon-Smith. And from them, I saw the excitement of translating recent scientific advances into the clinic, something I hadn't seen in other specialties. So that was very exciting. And I'm also grateful in particular to Ted Gordon-Smith, who showed me that process of being at the interface of science and medicine was extremely good fun. So I went from there, did more SHO jobs and registrar jobs in general medicine, and then decided to move into haematology. And from the beginning, I wanted to get into research, and I was very fortunate that I was able to get a position with Professor Ernst Huygens, who was one of the most original-minded people working in the UK at that time. And I am a huge debt of gratitude because he gave me immense freedom to do what I wanted. I went on and got a Wellcome Trust and then an MRC fellowship, and he basically let me do what I wanted and supported me entirely. And the other person I'm particularly grateful to is Tony Goldstone, who was one of my colleagues for 20 odd years. And we had a very productive collaboration, particularly over the development of autologous bone marrow transplant strategies. Yeah, I don't see it as one moment. I'm really lucky. I've enjoyed my whole career. I've always enjoyed looking after patients. And then on the research side, there have been a few different memorable episodes. Initially, I set up and designed all the protocols for the autologous bone marrow transplant program, including drug regimens such as BEAM, which are now used universally. I spent time in the States where we showed that hydroxyurea could increase hemoglobin F in patients with sickle cell disease, and this has now become a standard therapy for that disease. I then worked on the genetics of acute myeloid leukemia, particularly with my colleagues Rosemary Gale and Asim Khwaja. And I guess one of the high points was when we showed that mutations in the FLT3 gene had major prognostic significance, and this has now been incorporated into treatment algorithms worldwide. And then in the latter part of my career as a research manager, as a head of a department, I made a decision about 15 years ago to move the department in the direction of gene therapy and cell therapy. And that has been extremely rewarding. And we managed to recruit some really excellent people, such as Amit Nathwani, Martin Poulet, and more recently Carl Peggs and Sergio Casada. And it's really exciting at this moment in time just to see the impact immuno and cellular therapy is having in haematology. I also work with my colleague Peter Beverley using monoclonal antibodies to investigate the hemopoietic system, and we were the first people to use antibodies to purify hemopoietic progenitor cells, which were then used in a whole variety of studies of the biology of the normal hemopoietic system. I think working with patients and doing your best for your patients has been a constant source of pleasure, really. But the actual highs of exhilaration come with seeing the results of your research and your ideas pan out in the laboratory and then move into the clinic. So not one thing, but a series of things over a long period. Well, within the area of hemato-oncology, I've absolutely no doubt the greatest advance has been in supportive care. So improvements in looking after people with sepsis, better antibiotics, better blood products to support people when their bone marrows are suppressed. And those improvements in the way we look after patients has enabled lots of other innovations to occur. So it's enabled the intensity of chemotherapy to be increased. It's enabled bone marrow transplantation to develop as a specialty. So no doubt at all, it's supportive care. Well, certainly within my sphere of interest, I think the person that stands out is Donald Metcalf from Australia. He was in at the beginning of culturing hemopoietic progenitor cells, studying their biology. His work provided huge number of insights into differentiation, division of stem cells, and how they were regulated by growth factors. And of course, that's gone on to become a clinically important area as growth factors are now routinely used in the clinic. He certainly should have received a Nobel Prize. I think it's very difficult to know what are the really important developments going on at the time it's actually happening. It's only in retrospect you really know what the big advances were. I guess that at the current time the advances in immunotherapy are very important and likely to increase, and we're only just beginning to fully exploit the understanding of the human genome and the genetic changes that occur in leukemia and other malignancies. I think there are a number of challenges facing hematology, some of which are generic and global and some of which are specific to the UK. At a global level, there is dealing with the massively increased costs of novel anti-cancer therapies and how we're ever going to pay for them. And secondly, as we move into an era of personalised medicines, it's getting harder and harder to design adequately powered trials that really show whether new treatments work or not, and this is a major challenge. In terms of the UK, I think we have a specific challenge around the issue of whether haematology can remain as a joint laboratory and clinical specialty. It was that union of laboratory and clinic that attracted me to haematology, but it's increasingly difficult to justify. Many new consultants working seeing patients, they read bone marrow reports, blood reports, but they never actually use a microscope anymore. And so you have to wonder about the wisdom of them spending many hours during their training doing just that and having an exam that is heavily reliant on laboratory haematology. And I think there will in future be increasing pressure to separate out those two aspects of the specialty. I think the BSH, the British Society of Haematology, has had a very important role in bringing haematologists together to ascertain standards and to foster good quality research. I think that role may be a little diminished in more recent years, purely because people are able to travel to the American Society of Haematology and the European Hematology Association. So that role is a little less. And it's quite clear that the British Society of Haematology will have to evolve and change its role over time. The other very important thing that the British Society of Haematology did was that it set up a relationship with Blackwell's, which is now Wiley's, in the formation of the British Journal of Haematology, which has been a major journal of importance to the UK and internationally. I think it's a very difficult question to say what will be the biggest advance over the next 60 years. And the honest truth is I have no idea. I suspect it'll be more of the same, but better. The same questions remain. It's just the technology improves and answers it in a somewhat different way. I'm sure we'll continue to see more people surviving. I rather doubt that we're going to cure everybody in that time frame. One of the things I think technology will bring is that I think within that time frame, everybody will be having blood tests to look at their circulating DNA, looking for the earliest stages of all types of cancer, not just blood cancer, but all types of cancer. That people will be screened on a yearly basis, and that means we'll be treating a lot more early stage disease rather than late disease. This will make a significant difference in solid tumours, making the diagnosis earlier. It's a little less clear how beneficial it will be in blood cancers, but I'm sure it will be of benefit. And the technology to institute this is almost ready now. I think haematology speaks for itself, and if people experience haematology, there'll be a significant number want to go into that specialty. So the secret is to get medical students more exposure to haematology during their training. And this really means the society focusing on senior administrators within medical schools to make sure there's adequate haematology within the curriculum. It's not only a way of teaching haematology, it's a very good way of teaching general medicine. In addition, there needs to be pressure brought to bear on the General Medical Council. The haematology workforce is bound to continue to change. We'll have more and more consultants doing more and more specialist activity. Their workload, the amount of time they spend at the clinical coalface will undoubtedly increase, and there'll be less junior staff, and we'll have more work taken over by nurse practitioners. Well, I think we all hope the same thing, that all our activities will lead to the cure of more patients and that they'll receive treatments with less toxicities. And on the way to that, what I really hope for is that people practicing haematology can continue to have the fun while doing it that I've had. I think it's difficult to know what advice to give younger people coming through into the specialty, but I think a very telling point is that people of my generation not only enjoyed their training as medical students and as SHOs and registrars, they've also really enjoyed the work experience they've had in haematology. And there can probably be no greater recommendation than that for people to move forward into the specialty. It is true, however, that the job has changed, and junior doctors, although their hours are much shorter, their workload is much more intense. There's less time for reflection, less time for social interactions, and I don't think it's as much fun as it was, but that's potentially reversible. And my advice to people is to seize the opportunity, go into haematology and make sure it remains enjoyable.